Okay. This is for what? What's this one for? Patellofemoral arthrosis. Something back behind the knee. The runner's knee, they oftentimes call this, can lead to osteomalacia of patella, right? So the problem is on the back of the kneecap. Maybe this could be, who was talking about fat pad the other day? Was it in this class? Fat pad, so something may come down our knee and that could cause this problem and so on. Anything behind the knee can result in this. So what you do is you just come down here, and this test is patellar grinding, also known as Clarke's test. So I'm just going to push the knee inferior, and then you hold it, and you have the patient contract their quads. Now, when they're contracting their quads, you want to hold that there, and that can be miserable. You guys all remember this test? So I'm letting her patella slide, but you really have to get enough pressure on her so it doesn't slide, and it can be miserable. But if they can't hold a contraction, or of course there's deep pain under here, then that's a sign that that's a problem, right? Okay, it's Clarke's, and next one is Fouchet's or Fouchet's. I don't know how you all have said it. I always just say Fouchet. I'm going to push down on the patella and ask the patient, does that cause you any discomfort? And if the patient says, no, that doesn't, then we're going to rub it in, right? We're going to take it, we're going to compress it, and we're going to rub it back and forth and see if that causes on the patient pain. Now, I'm being very gentle when I'm doing this. She can tell you this. You really, remember, an orthopedic test is meant to do what?
Inflict
Meant
pain.
to hurt the patient. So you guys need to get in there with some vigor and do these tests. You know, just practicing on one another. You don't want to hurt one another, but yeah, when they do them, they want them to be effective. Okay, next. Thank you, Brian. Ballottement test, that is just for effusion. That means that the fluid has to be in the joint. Has everybody got that? And so they sometimes call that water on the knee. Anybody ever heard water on the knee? What you do is you just milk the fluid down, the water into the bottom part of this joint, and then I'm going to take the patella and I'm going to push it in. And if you get like a click sound, that means that there's a whole lot of fluid in there. But it's supposed to, because the fluid behind there is supposed to be, I guess, like a little cork, pushing a cork down in the water, and it just sort of pops back up real quick. Okay. That is not necessarily from meniscus or anything. That's just telling us that there's effusion. Okay, and it could be meniscus. It could be, you know, retropatellar, anything. But that just means you have a lot of fluid. Drawer, Lachman's, lateral pivot shift. All of these are for what? ACL primarily. The posterior drawer is for PCL. And we talked about that, how, what does, in the non-weight bearing position, the ACL prevents what movement?
Anterior movement of the tibia.
Anterior movement of the tibia on the femur in the non-weight bearing position. So we're going to see if that's true, right? So if we suspected that our patient had an anterior cruciate ligament damage, you know, from all of the things, and we're going to bring this up, we're going to then sit on the patient's foot like this. We're going to grab, and I want you to grab right here along this tibial plateau, right in here. Did we start palpating this in this class yet? No, okay. But right here, you'll feel that there's these two little indentations right in the joint line, and you'll be able to follow that back right through the joint between the tibia and the femur. The femoral condyles in the top of this tibial plateau. So you want to put your thumbs here. So, and then when we're drawing, remember you don't want to pull on the patient's calf. Okay, don't pull on it. I don't care who they are. It's awkward. It's uncomfortable. So stay here and just pull. And we're going to see if we have any translation. You'll see some translation, which is normal. There's a little give in there, but it shouldn't be 6 millimeters. And if you have the sag sign, you don't have to do the posterior drawer. But a lot of people, when they're doing the test, they always make sure before they do it that they put it back into the neutral position and then they pull it. Or if it's sagging the other way, then they put it back neutral and then they push it. But you'll see that's for anterior and posterior drawer. Posterior cruciate ligament prevents what movement in a non-weight bearing position?
Posterior movement of the tibia.
Posterior movement of the tibia on the femur in the non-weight bearing position. Okay, so that's your drawer test. Lachman's, the whole idea behind Lachman's is we want to take the quads out of play. It's possible that the quads could be tight enough that they could actually inhibit some movement of the tibia on the femur. So we want to eliminate that, so we'll straighten the patient's leg out. And some people just go like this, they hold it here, and then they pull, right? But most of the time, you'll see this test is done like this. People grab here and here, and they just pull, like this. Right? So I'm stabilizing the femur, and I'm pulling on the tibia, right? So I don't care how you do